Well, y'all been so quiet. Normally they like the background banter. Isaiah ain't talking no smack. He in a CMU shirt talking no smack. I'm bedrock out today. What? Boom, you're on.
All right, man. It's always exciting to be on, right? Today is going to be another of those opportunities for you all to ask the doctor. Can you hear me, Doctor? Dr.
Yes,
Deborah
sir.
Furholden?
Yep.
Doctor. Okay. Oh, I'm going back in my own. Dr. Jennifer Rejoy Edwards Johnson. You can hear me. I'm making sure you can hear me. Dr. Carolyn Deborah Furholden can hear me as well. And so, hey, listen, I'm always excited about the opportunity to get out and share some information with our friends from this community who are wrestling with the decision to get the vaccine, being on the list to get the vaccine, trying to understand the difference between Moderna and Pfizer and this new Johnson & Johnson opportunity that's in front of us. What we're navigating right now by way of administration and distribution and mandating equity in the process. I mean, just lots of questions are floating around in our community, and I'm sure you and your friends, your peers, your family members are asking many of those same questions. And so we are going to jump into an amazing conversation with two amazing docs. One epidemiologist focused on public health with 20 years experience out of Johns Hopkins University, and then the other, Dr. Jennifer Edwards Johnson, Michigan State University, family physician, moving to the Flint area to do work through Michigan State University, but from the Lansing area, our cousins from up the street. We all drink Faygo Pops, right? All on the same team. So if you will, please share. The more questions we can get into the chat, the more questions we can answer, the more diverse the questions are, the more I would say vibrant the conversation will be. So again, share with your friends, share with your family, those folks that have asked you questions throughout the week about Johnson & Johnson, about Moderna, about Pfizer, about the vaccine in general, about what it means to have herd immunity and all those other things that we've asked ourselves and our family around the dinner table. Share with those folks. Get those questions on the table. That way the doctors can answer you. Again, I am the sincerely ignorant guy who leads a public charity here. My expertise is in the social sector, not in medical science. But these folks here actually have the answers. And so right away, I'm going to start by just allowing you to introduce yourselves. I know we've done this a few times, so many people know you, but if we can start with you, Dr. Edwards Johnson, Dr. EJ, as I'll probably say throughout the rest of the broadcast. Dr. EJ, introduce yourself, and then Dr. Furholden, you'll introduce yourself next, and then we'll jump right into questions. Hey, Karma.
Thanks. I'm Jennifer Edwards Johnson, Community Assistant Dean of the Michigan State University College of Human Medicine in Flint. Jennifer Edwards Johnson, no Marie Joy.
Marie Joy, where did that come from?
That's what you get for telling him your middle name.
I didn't tell him. He found it on the internet.
The internet knows everything.
I'm Dr. Deborah Furholden. I'm a PhD level epidemiologist. I've been at this for about 22 years, postdoc. I'm also the director of the Division of Public Health at the College of Human Medicine under my fabulous community dean, Dr. EJ. And I also am the Associate Dean for Public Health Integration. So I work to help integrate public health and clinical practice across our college, and we're scaling up those efforts on campus more broadly.
Feel free to throw questions into the chat, whatever comment box you're in. But before we even jump into that, you got hashtag mandate equity. Talk about it. Tell me something.
Mandate equity is we on the move, and so we'll talk about it. We got this new Johnson & Johnson vaccine. I'm pushing this out around COVID, but the need to mandate equity is much more than that. So mandate equity is about people using their legislative power and other authority to do the right thing and to level the playing field. And I say, where there is goodwill, there's a legislative way. Much of what we are seeing in COVID is because we don't have any real skin in the game and no requirement that people ensure that not only can they get this vaccine to community fairly and equitably, but that they can fairly and equitably get it injected into people's arms. So mandate equity is the movement to put the pressure on our president. It will be on March 13th, it will be exactly 1 year since former President Trump declared COVID-19 a national emergency. I take the case that equity in vaccine distribution and administration deserves a similar calling, because when he declared that national emergency, Congress rallied, we changed societal norms, we rolled out substantial resources, and we started to do the work to deal with the pandemic. We need to do the work to deal with equity and who's having access and who's getting this vaccine in their arms. And this will go well beyond COVID because it applies to so many other conditions, health and non-health, wealth, health, racial equity, I believe, is original sin in America. So mandate equity is to use laws and policies and power and authority to level the playing field.
So one, I appreciate you saying that. I think I have several questions. One might ask, are we starting at third base when we start talking about mandating equity without education around what equity is, or even having a shared truth or shared understanding of the racial history of this country? And so when we're asking people to mandate equity or to use equity as its tool of choice as we engage with communities, how many people really know what equity is? We're not talking about diversity. We're not talking about including voices. We're talking about equity, which is a step up. And it's a leveling of the playing field. How many people really know what that is? And beyond just people who know what it is or the racial history of the country, how many people in power actually understand the unearned privileges that they have anyway?
Yeah, I say privilege is being born on third base and acting like you hit a triple. And that's what privilege is. Born on third base, and you said third base, but acting like and feeling as if you hit a triple. And we know because of the long-standing, chronic, enduring effects of how our very country was set up. I don't know if anybody has watched amend, all about the 14th Amendment, but it's a deep history about how we were not even counted as whole human beings for a very, very long time. You are not going to make up the historical impact of being considered a fraction of a human being, of being considered property in 1 or 2 generations. So what people don't realize is whether or not you want privilege, you have it. We, by very design, one could argue that our society is working exactly the way it was set up, exactly the way that it was intended. And if we're going to actually turn that around, we've got to, as you say, have a real reckoning, a truth-telling, come to Jesus conversation about the history of our past and what that means for our future and our present and our future. Everybody does not have the same opportunities. And we also, many of us, inherited the legacy of oppression. And we're having to overcome and operate outside of that. So the pull is also that community is working really hard. We're pushing very hard. You got a lot of really strong, smart, brilliant people who are working really hard to establish equity in COVID and healthcare and business and finance and all these things. But we have no legislative pull. So mandate equity is about getting some pull from those in power to complement all the tremendous push. And think about pushing a boulder uphill. If you got somebody at the top pulling that boulder, that's a whole different experience than pushing by yourself, knowing that if you give up, that boulder is going to roll over you. So we need legislative pull for all of the community push for equity.
We go come back to that. And I'll tell you this, I just wanted to make sure the mic was on, want to make sure you was warm, make sure the blood was pumping. We do have some questions in the chat that take us off of mandating equity, but I'm certain that equity will come up as we begin to have this discussion. And so the first question is, I want you all to talk a bit, right? So this is Karma calling us to talk. I want you to talk about the effectiveness or how effective the Johnson & Johnson vaccine will be compared to the double shot of the others, both Moderna or Pfizer. I would go to Dr. EJ first, and then Dr. Furholden, you can come in behind.
Absolutely. I think to talk about the efficacy of the Johnson & Johnson vaccine, we got to talk a little bit about Moderna and Pfizer. So that's what we've heard about. That's what we've been working with. We understand Moderna and Pfizer are mRNA vaccines that are around 94 to 95% effective. And when we say effective, we mean that among those who received the vaccine, 94 to 95% did not get, in the case of Moderna and Pfizer, did not get symptomatic COVID infection. Now, when we talk about the Johnson & Johnson vaccine, I think there are a lot of things that are important. So the Johnson & Johnson vaccine is a one-shot vaccine. It can be stored and transported a little more easy, and that's some of the things you may have heard. And when we talk about efficacy rates, the really important information is that we have seen no deaths and no hospitalizations with the Johnson & Johnson vaccine. What we have also seen is that in the US, it has an efficacy rate of about 72% for severe to moderate disease. And then when we talk about global numbers, that number drops a little bit to about 66%. And part of that reason is the Johnson & Johnson vaccine trials were going on when we were starting to hear about variants. So variants started to play a little bit into that number. And we did see a slight drop off in efficacy with the Johnson & Johnson vaccine with some of the variants you commonly hear about, like the South African variant, et cetera. But I think probably the most important piece to understand is that the Johnson & Johnson vaccine still had no deaths and no hospitalizations, and is a one-shot vaccine, which is great to hear.
All right, Dr. EJ, if you don't mind me following up, I've heard docs say that the Johnson & Johnson vaccine is a game changer.
Yeah.
For more reasons than just that it is a one shot, that it's a game changer. Could you talk to us about why people might say that, why we might be hearing that in the news?
So the one shot piece is pretty important, right? When you think about people not wanting or not being able to get back out for their second dose, people having concerns around getting the shot, theoretically, any side effects that might happen with the first dose, you're increasing that potential with having two shots, right? So there are lots of reasons why having a one-shot vaccine is a really great option. It can be stored and transported very easily. It can be stored in doctors' offices where they might not have the really, really cold refrigeration techniques that are needed for the Pfizer vaccine particularly. But also just a one-shot vaccine means there's more vaccine to go around. And the other data that I kind of didn't mention is one of the things we're also seeing with Johnson & Johnson is as you get farther out from your shot, you get about a month and a half out, we're seeing increases in the level of efficacy. So we're getting closer to that 90% number once we get out to sort of 6 weeks out from initial shot. So we're really seeing in that aspect, it can be a game changer. If we can get these into physicians' offices, if we can get this widespread, it's a real opportunity to vaccinate much more of the population than we originally thought.
And then can you talk a little bit about immunity, the comparisons between Moderna, Pfizer, and Johnson & Johnson? I know we've talked in times in the past, we've talked about waning immunity and the amount of time it lives before you might need a boost. Is it any different for Johnson & Johnson?
So what we're seeing is the vaccines, though they use different technology, work the same way, right? They boost your body's ability to create an immune response. Basically, you get a little bit of the instructions for your body to create an immune response against this spike protein that we've talked about a few times. So the waning immunity concept is kind of similar, and it's kind of in line with the idea that we see an increased response and efficacy farther out. What we're seeing is that your body's had more time to produce a robust immune response. And so that's one of the things that we're seeing in all of the vaccines.
All right. Do you have anything you want to add, Dr. Furholden?
No, I think Dr. EJ hit that right on the head. So there's benefits. There's benefits. I'll just say that. But then it does raise the question. And I'm wondering if anybody's going to ask, because it does have a lower effectiveness rate. But it also has the added benefit of it's only a one-shot dose, and it doesn't have all of those storage requirements. So I think Dr. EJ hit it like right on the head.
Well, tell us about the tiers. I mean, you come from an epidemiologist. Hold on. I'm not going to mess this up. So I'm just going to say you are an epidemiologist. And so you think about public health as a focus, as a way of addressing community issues. So when is this going to be available to folks under 50? And talk to us a little bit about the tiers and how they're rolling out right now.
So it's interesting because what we're trying to do is get the feds to relax up some of the requirements. And a lot of this is resting in the hands of states, because if you're in communities, and this is where data becomes so important. If you're in communities where you've got more cases in that population and even worse outcomes, if you're in a community where you've got a lot of hypertension and diabetes and other health conditions, and that 50 age group, or even that right under 50 age group, we don't necessarily think the whole point is to provide protection when and as fast as we can as it's needed, right? So you might have a community that has a lot of 65-year-olds who are relatively healthy. And that is what you'll see if you go to a community that has greater proportion of 65-year-olds who are also wealthy and have some of those other protective factors for health. So the feds have a timeline. That group is coming up like in the next wave, but it's a supply and demand problem that we have right now. The demand far exceeds supply. And we've got hundreds of thousands of people in every state on the wait list. So even if I were to tell you when they say it's coming up, all it will take is one thing to happen and one vaccine go to the left, and those numbers will not hold up. What I do believe we need to do is really, again, put our eye more towards equity. And if our goal is to make sure that the people who are most at risk and most vulnerable get it, there are people right now who are in the under 50 category who are eligible. If you are in one of the other categories, in Detroit, as an example, they've dropped the age requirement. So they can now go down as far as, I believe, 60, right, Dr. EJ?
Yep.
In Detroit, they can go down all the way to 60. Why? Because they saw that 65 was too high. They were seeing similar death rates and similar rates of complications in adults 60 as they were seeing in adults 65 and 70. So I could give an answer, but nobody can really say that with certainty. But what we do know is if we want to do it equitably, we've got to actually be guided by the data and what is a real underlying sense of fair play.
I got a question then. So as we're talking about mandate equity, because you leaned into mandating equity, is race considered a pre-existing condition?
So race is not a pre-existing condition. And I want to be super clear. There's nothing about race that increases your risk for poor health. What your race does is give way to experiences of racism and discrimination. That stuff will kill you. Right? We're like
No,
literally.
but I got it, right? But I only asked the question because the indicator is that I'm Black. The indicator isn't that I'm poor if I live on the north side of Flint. And so what are we using to indicate a person's ability to get access to quality healthcare, get access to healthy foods, get access to housing that's appropriate? All of those things that support healthy living.
So I'll speak specifically about two things, because there's a particular movement afoot in Michigan, and it's starting to happen in other places. I've been looking and following what they're doing in Maryland and in Baltimore, because physically my butt is in the chair in Baltimore right now, right? This in the state, in Michigan, we've been trying to get 2 additional indicators added to further prioritize distribution, and that's race and the social vulnerability index. And the reason, so the race and social vulnerability are not about circumventing the existing eligibility categories. What we're saying is, if you're in a community that has a high percentage of underrepresented minorities, or is higher on what's called the social vulnerability index, we know that those communities are at greater risk for poor health that predated COVID, and also at risk for poor outcomes from COVID. We could easily instead take as a proxy the community case rates and the community death rates. Those should also be considered. But the problem is, there's some among us who say they have goodwill, but only want to prioritize community based on the proportion of people in the community that are 65 and over. And the problem that I have with that system is, living to be 65 and over is privilege. It takes a whole lot of privilege to be able to live past 65. So now let's multiply and scale that up. If you live in a community where you got a high percentage or a high proportion of the residents that are 65 and over, you've got concentrated privilege in the community. Chances are those communities tend to be a lot wealthier, and they already have a lot more resources. So my thing is, that might be well-meaning, because we know that the older you are, the more likely you are to have complications from COVID and also to die from COVID. But to stop only at that measure and not include some of these other measures of risk and vulnerability, to me, is to miss the mark on really trying to have it be equitable, and that everybody has a fair opportunity to get it.
The next question takes us down that same line. What can the community do to help boost mandate equality? And I would just ask you in this, because that's what the question says. I would like you to explain the difference between equality and equity and offer some examples.
So I think equality is very different from equity, right? So, I have 3 kids. They're of different ages, different sizes, different genders. I wouldn't at dinner time give everybody the same amount of food, because the nutritional needs of my 21-year-old son might be different from the nutritional needs of a 3-year-old, or of a 7-year-old, or of an 8-year-old, right? So equality is not what we want to be looking at, because equality would imply that everybody's needs are the same and every community's needs are the same. And we know that's just simply not true. Communities that have been harder hit deserve more. Communities that have been historically disadvantaged will likely need more to overcome the impact of that historical disadvantage. So equality it's not a bad thing, but again, it's not going to get us to fair play and opportunity and access. If we just give everybody the same thing, some people will get a lot more than they need, and some people will get substantially less than they need.
All right. I hope that answered your question. If it did not, if you can jump back in the chat and just ask it again, then I'll make sure that we get back to it. She might have meant, what can the community do to boost mandate equity? So that might have been the question. Well, I tried to give it both, just in case that was the question.
So I'll tell you what the community can do to mandate equity. The mandate equity website, do not go to it right now. It's going to be live and in living color tomorrow. We've drafted, myself and Isaiah and a bunch of others, and Dr. EJ have all chimed in on it. I've had a few friends and colleagues and others who are working on something else that we'll roll out at another point in time around how we really plan on eradicating racism. We'll do that later. But there will be an opportunity for people to sign on to an open letter to President Joe Biden. And you can also be reaching out to your elected officials. The Michigan legislature specifically has is underfoot in trying to undo much of the goodwill around equity, right? So the legislature is moving to disallow the use of social vulnerability index and race as additional criteria to further prioritize communities for COVID vaccine distribution. So you need to let the people know that you voted for. I don't want that. I want to make sure that the communities that are most in need are the communities that are first in line and that they're being served proportionate to their need. So that is something that people can do if they want to help push that movement. And I also ask people, use the hashtag mandate equity. You know, if you've got a story to share and an experience, your 80-year-old grandmother has been on the list, is on 2 or 3 lists, can't get her way through the maze, can't get out of the bottleneck, hashtag it. Post it, put it on your social media, put it on your Twitter, put it on your Instagram, put it on your Facebook and say, this is not fair that I've watched my wealthy neighbors or my white neighbors or my neighbors with privilege, because privilege ain't just about race. It's a whole lot of, and not all Black people are poor and not all minorities are poor. It's a whole lot of people who just jump the line because they know somebody. So speak out about it, use your voice, put the pressure on your elected officials and use your voice and hashtag mandate equity.
All right. So the Moderna and Pfizer vaccines didn't get retested for the variants. I think they're asking a question of something you were sharing earlier with Dr. EJ.
So the Moderna and Pfizer vaccine trials are ongoing, right? They're even enrolling. They've been in, well, they closed enrollment, but we're enrolling for ages 12 to 18 most recently. So that data will be forthcoming. But our most recent data on the Moderna and Pfizer vaccine, we don't have very good data on the variants. There are sort of surrogates for that data that suggest we're doing really good against the variants, but we don't have the type of data that we have from Johnson & Johnson for those vaccines.
Perfect. Oh.
I believe he just froze.
Yeah.
Okay. All right, cool. And so I can just add one quick thing about pharmacosurveillance. We're going to have to continue to monitor these things. And this is a point that I really want to stress to people. If we don't do our part to stop community spread, what we're going to see are more and more variants. A virus has only one goal, and that is to find a host and survive and thrive and grow and proliferate. And every host it goes to, we run the risk of a variant popping up. And the more hosts that it finds, the more variants that we will see. So if we want to stop all these variants, we've got to stop the spread. Variants happen when the virus replicates. The virus cannot replicate out in nature. It has to have a host. So the more that we go back to business as usual, and even in Flint, the community case rates have gone up. We were down below 3%. This week, we had a 1.3% jump. We're now well over 5% again. Things are going in the wrong direction. It's 100% a function of what happened with reopening. And do I understand the weight of things being closed? Yeah, of course I do. But if we don't stop community spread, what we're going to see are more variants. But the pharmacosurveillance is about monitoring ongoingly the effectiveness of these vaccines against these variants. And if I had to guess, we're going to see, this is going to be something very similar to flu, and we're going to see seasonal vaccination, and we're going to see seasonal vaccines that are going to be developed every year.
Along that line with the mandate, in terms of mandating equity, I think that's a really important piece, because not only do we see variants when they infect more hosts, we see variants when they infect sicker hosts or people who are likely to be more sick. So those people who have more chronic health conditions, the people who may not have access to primary care or access to healthcare resources, those are ripe grounds for more variants, because the variants are going to find new ways to adapt, find new ways to make people more sick. And so when we think about mandating equity, it's important that vaccines are getting to communities, because communities that have no resources are the most likely breeding grounds for new variants.
All right, we got a second question here, just asking about the side effects. Are the side effects similar with Moderna, Pfizer, and Johnson & Johnson?
Yeah, the vaccine, the side effects are very similar, and actually early data showing that with Johnson & Johnson, there's actually slightly fewer side effects. Some of that is the result of it being a one-dose vaccine. We know that with Pfizer and Moderna, you see more side effects with the second dose. But largely, I think for fever, we saw about 9% of participants have fever, and like 0.2% of those were even fever that required any sort of intervention or required a change in their daily activities. Generally, the side effect profile has been really low.
All right. And we've talked quite a bit about the long-term effects of any of the vaccines and the rigorous process that you have to go through in the US to get a vaccine kind of officially out there. So, and I don't even know what the term is for officially out there in a vaccine. See, this is in my world. But have they been studied is the question that's been asked.
Have the side effects been studied?
I would say the long-term effects have been studied.
So we don't have that data yet. And I'll let Dr. Verholden answer this question, but we have about a year's worth of data from our Pfizer and Moderna vaccine. We don't have 5 and 10-year data. But we feel pretty confident about the mechanism by which the vaccine was produced. We feel really good about what we've seen so far.
What gives you that level of confidence, if you don't mind me asking, and pushing a little?
That's an important question. All of the vaccines enrolled large numbers of participants. And so when we have vaccine trials that are this large and this robust, it really gives a good amount of confidence. But also, right, we vaccinated a significant portion of the population, less than we would have liked to. And we can talk about mandate equity and who we vaccinated, but we've still vaccinated a lot of people and been able to look at those side effects. And we're not seeing significant events, especially relative to other vaccines that we administer.
Can I add one thing to that,
Please
though,
do.
which is important? The way that vaccines work, typically you don't have adverse and negative effects from vaccines that show up years down the line. Typically, what you will see, if you're going to have an adverse effect or a bad effect from a vaccine, it will show up very close to the time that you got the vaccine. Within hours, for some people, it's immediate, within hours, within a few days, and definitely within the first week or two. So it's so trivial and minor, it's really not worth talking about. But that's just not how vaccines work. If they're going to have a negative effect, those negative effects are going to show up right now. The other thing that I want to say specifically about the Pfizer and the Moderna vaccines, they are literally giving you, there's a whole viral molecule. That viral molecule has the spike proteins on the outside, the instructions on how to replicate on the inside, and then the real thug, the actual viral, genetic sequence on the inside. The vaccine is giving you one piece of the instructions on the inside of the molecule to make just that piece of the virus that is on the outside, that is the key that would unlock your cell. So if people are worried about whatever effect they might get from the vaccine, realize you're getting just a little piece of the least dangerous part of it, which is the little piece of the instructions. So whatever concerns you would have from getting the vaccine, realize it would be times 8,000 if you actually got exposed to the virus. Like the vaccines that we have out right now are probably the safest in the world of vaccines that we've had to date.
Okay, so 2-part question. The first part you've kind of touched on. So if you can touch on it early and then go into the second part of the question, which is one that you haven't. Thinking about immunity and how long it will last, do we anticipate that people will need to get a COVID vaccine every year, like the flu shot? That's the part that you've already touched. And if so, do you think we will have the same supply distribution issues that we are seeing now in the coming years?
So I think Dr. EJ should take part one.
All right.
So I agree with what Dr. Verholden said earlier. I do anticipate that we will have sort of a yearly or seasonal vaccine that we distribute. I think the other piece is we've talked a little bit about the potential need for a booster for Moderna and Pfizer shots. That potential still exists as we see more variants, but a lot of it will depend primarily on our ability to prevent new variants from popping up, which means doing our job in preventing community spread and decreasing the likelihood of variants. I'll touch a little on the next part if that's okay. I think our supply and distribution issues are directly a function of our ability to kind of get new vaccines on the market. Johnson & Johnson, you see, is on the market now, and it has significantly increased our ability to vaccinate the population. I think that goes a long way when we think about potential supply and distribution issues in the coming years.
Yeah, the only thing I would add to that is what is predictable is we're going to see a lot more vaccines also coming on the market. It's going to be a double-edged sword, though. It's going to bring a dose of hope and a new dose of hope, but it's also going to bring a whole new round of questions, right? Because the different vaccines that are coming out, many of them are built on different technologies. So we spend a lot of time trying to explain to people what this new mRNA vaccine technology is about, how it works, what it is, what it isn't, what it does, and what it doesn't do. The Johnson & Johnson vaccine is a different type of vaccine. And many of the other vaccines that are coming out, they'll fall in about 3 or 4 different families of vaccines. But with new vaccines, that will solve some of the supply chain distribution problems. And once we get it under control, this will just be a sort of a part of our normal, like how we do business. But it is also going to bring some new questions.
All right. One of those questions is here. Jay Hairston says, I've seen a vaccine rollout plan for Ohio that started with listing the elderly, teachers, then pregnant women, and then so forth. Why would they list pregnant women if we aren't sure about the vaccine and pregnant women, unless that only applies to the Pfizer vaccine and not Moderna and Johnson & Johnson? I know, Dr. EJ, I know you leaned into this one in a call that we had previous.
Yeah, I think the most important thing to think about when we think about who gets a vaccine and who doesn't, or who should get a vaccine and who shouldn't, is the risk, right? So what is the risk of a pregnant woman getting COVID is the question we ask. And what does that risk look like if they get the vaccine? And based on everything we know, what are the risks with a pregnant woman getting the vaccine? And what we do know is that the risk of COVID in pregnant patients is significantly higher. The risk of mortality, the risk of COVID-related illness, all of those risks are so much higher than any risks we have seen related to the COVID vaccine. And that's how we make decisions, not just with COVID, but with anything. It's how we make a decision on whether we put a pregnant woman on any medication or whether we continue a medication they've been on. So we take that same kind of theory, that same practice pattern, and we apply it to the COVID vaccine. And we say, what are the risks of COVID? Are they really high? Are they really significant? And because they are, we look at the very low risks of COVID vaccines and what we know based on vaccinations thus far. And we say that's not a high risk and we'd rather protect against COVID. And so across the board, we've been including pregnant women in the vaccination protocols.
Thank you. Anything to add to that, Dr. Verholden?
The only thing I would say is I've heard from a lot of now folks who are pregnant who've gotten the vaccine. And I've also heard from a lot of parents who have infants who have gotten COVID. And so, the one thing I can say is the clinical trials are underway. They're moving the age down because, it's decent logic to me. People have asked the question, wait a minute, if my child can't get the vaccine, why can my fetus get it? And that is a logical question. And the only thing I can say to that is based on the clinical trials data and the data that we have so far, it doesn't appear to pose any excess harm. Again, that's why you need a healthcare provider. I can't stress that enough. If you didn't know that coming in, and there are a lot of people that it's a myth that most people don't go to the doctor because they don't have insurance. That is actually not the reason that a lot of people don't go to the doctor. They don't go to the doctor because many of us only go when we don't feel well or when we're sick or when something bad happens. And that's why you need a healthcare provider. The healthcare provider is your partner on your health team. But make no mistake, you are the captain of that squad. You are the captain of your healthcare team. But you need it'd be like having a basketball team with no forward. I'm gonna watch the sports analogies because I'm pretty bad with them. But you got to have all the
Point guard.
positions filled. Yeah, point guard. Whatever.
I wasn't gonna correct her. I was gonna let that ride.
I don't know. A football team with no quarterback, right? I'm just saying. My point is, a healthcare provider, a trusted, knowledgeable professional, is a critical member of your healthcare team, right? Exactly. Dr. EJ, family medicine physician. And what's cool for me, as my kids got older, it became easy. I actually have my provider is double boarded in internal medicine and pediatrics. So me and my kids all see the same primary care physician. She does pediatric care and she also does family practice and adult care. It just works well for us. She knows all of us. She knows our whole family. We all go together for our annual exams, for checkups, for problems. If anybody out here does not have health insurance and that actually is your barrier, every city, every state has local health plans. Literally just Google, put in your county name and local health plan. There is an entity that their job is to make sure that people have insurance. And if you don't have insurance, put in your city and state or your county and Google FQHC, Federally Qualified Health Center. It is the job of the Federally Qualified Health Center to be the stake in the ground, especially for the medically underserved, to make sure that everybody, despite insurance, homelessness, all of that, has access to a primary healthcare provider. And many of the FQHCs are health homes, like the one in Flint that we have. They offer vision, dental, obstetrics, primary care, behavioral health, mental health, all of that stuff. You got to have a primary care physician to help you navigate and make these decisions.
So let me lean into mandating equity again. I'm gonna layer on top of Jay's question, if you don't mind, Jay. You started with elderly, and then you moved to teachers, and then pregnant women, and then so forth. And for me, so forth includes all of these other tiers that we've heard about. We've heard about teachers, we've heard about first responders, we've heard about clergy, right? These folks that can be in the line because they are priority. How does that intersect with mandating equity? I mean, do we have? Quite frankly, does it align with our racial demographics in the state or in the country when we start putting teachers first, or we start putting healthcare first responders first, we start putting clergy first? I can get the elderly, right? That makes sense to me, right? That one makes sense because those are the folks that are most vulnerable to the sickness, to being sick, right? But then when you start adding in these tiered jobs, I question whether or not that aligns with the racial makeup of our communities and equity, those who've been marginalized the most, those who live in high concentrations of poverty where access are a problem. Like, how does that line up, or how do those two things intersect?
So it's not just about impact and marginalization. It's also about exposure. So the reason, as an example, because you brought up teachers, that teachers have been pushed forward to the front of the line is because of school reopening. Right? So if people are at higher exposure risk, and if you think about our early categories, they're either at higher risk for exposure or higher risk for a bad outcome, right? So higher risk for exposure, that's why frontline healthcare workers were included. That's why if you look at the data, you'll see a lot of people in their 20s and 30s were in that initial batch of people who got vaccinated. And you might say, but wait a minute, 20s and 30s, the death rate in that group is so low. But those are, that's a big age group for frontline healthcare workers. And frontline healthcare workers, because they're interacting with people in the healthcare system and people who are COVID positive, are at much higher exposure risk. So with the onset of school reopening, teachers are now at exposure risk. And it's a myth that kids cannot contract COVID. That's not true. It's a myth that kids don't have impacts from COVID, because some of them do. And it's a myth that we haven't had children who have died from COVID. It's a very small number. And if you compare it to death in older adults, it's night and day difference. The likelihood of death from a child is mostly due to other complications. And Dr. EJ can talk about that if somebody wants to know more. But kids are like little carriers. So the kids might be positive and doing okay, but they're exposing the janitors, the teachers, the admin staff, the paraprofessionals in the school. So we said, we're going to send kids back to school, and that's a big push. A lot of parents want their kids back in school. They're tired of being lunch ladies and homeschool teachers and PE teachers and all of that. But if we're going to send the kids back to school, the people who have been tasked with their care and provisions all day do need to be prioritized. It's about exposure risk, not just risk of bad outcome. That's why we started to prioritize some of these other groups. Same thing falls true with clergy. Many of the clergy are the only people who are able to be in the hospital and at the bedside of people who are dying from COVID or who are battling with COVID complications. Similarly, clergy oftentimes go out and do visits. They go and visit with their people. And for all the people who are really struggling with the social isolation that this pandemic has brought on, clergy and other faith leaders have really backfilled that gap. Again, I would argue that they are essential and that they are frontline, because they're not just dealing with, a lot of people will talk to their clergy about their physical health before they will a healthcare provider. And they're also tending to people's social, emotional, behavioral, and spiritual health.
So tell me this, Dr. Deborah, does that help us to understand the racial breakdown? I think back February 23rd, 24th, late last month, the state's data came out, and it suggested that a significantly low number of Black people of color, had access to the vaccine. Is that because these two things do intersect in a way, or is that a whole different reason?
No. And I want to dispel that myth too. Black people have been vaccinated in the state of Michigan at half the rate of their white counterparts. And hesitancy is not the problem. So let's throw that out the window. How do we know that? Because we've got tons and tons and hundreds of thousands of Black people on wait lists, not just on one wait list, but on multiple wait lists. Okay. So hesitancy is not the problem. Then if you actually look, and we've done this in Genesee County, we've broken the grid down. In Genesee County, which is where Flint is located, for anybody not in Flint, is very close. According to the health officer, about 18% of the people who've been vaccinated in Genesee County are African American, compared to about 21% representation in the county. We're waiting for a confirmation of that data, so I'm not going to speak that with any certainty. But I do know, based on what we see, it looks like we're doing better. But we still have inequity. And I wouldn't put any weight behind that until I actually get the real data behind it. Mm-hmm. The problem is people have been able to jockey their way to the front of the line. And if you look at how the vaccine is getting distributed, it went first to big hospitals and some to health departments. We had major issues around how people even got on the wait list. In Genesee County, you had this little time window on Monday from 5 to 6 to call or sign up online. So internet speed was a rate limiting factor. It literally, not even whether or not you had internet, but how fast it was. Remember old school when they'd be giving tickets out on the radio and they would give them the caller number 38 because you was on, WJZ 38, whatever. And you would call and it would go, That's what people experienced during COVID. But they experienced it when they were calling, and they experienced it when they were on their regular Boost Mobile, whatever, regular speed Wi-Fi.
First of all, that was really good. You should go to your 90s analogies way before you go to your sports analogies. That was good.
The 90s, I agree. I have to.
All right. I clearly know more about the 90s than I do sports. But my point is, and then literally, and I want to make this clear for people, when the categories first rolled out, and it was the people living in group facilities. And by the way, that did not include prisoners, which I don't understand. Some states and some counties were able to push for that. But to me, that is the most vulnerable among us, because they have no ability to social distance, no ability to physical distance. And many of them have to pay for their own PPE. But when we had those original groups that came out, dang, I forgot my point now. I lost it. I forgot it. You got me riled up with my 90s analogy. I forgot, just like that. Damn, that's messed up.
Let's come back to it because we got a couple of questions in here. Uncle.
All right, we'll come back to it. Get the question.
So we got a couple of questions. So one, let's start with Cousin Ray. Said, will mandatory vaccination be implemented in schools?
Well, it's possible, but we're not even close. Let me tell you why a mandatory vaccination isn't going to come. Because we don't even have the supply. So they're not going to make something mandatory that we can't even provide. So is that a possibility? And this came up on another call that we did. It's the EEOC, Equal Employment Opportunity Commission. it's decided, this came up, I forgot, I couldn't remember what it was, decided that if in fact employers or particular sectors did mandate it, that it wasn't in their purview because it wouldn't fall under the class or the category of discrimination or unfair hiring or firing or whatever. So the EEOC basically said, not our problem. It's possible. It's not really the thing I think that we need to be tending to right now, because we don't even have supply to match a mandatory vaccination policy in any sector.
All right, second question here. Ms. Bailey, how are you? Will or should those of us who have taken the vaccine have our antibody loads tested periodically to see if we need a yearly vaccination?
I think that's unlikely. I've seen people get antibody tests to see kind of, are they protected or not. I suspect that, like we kind of mentioned earlier, that we will have a yearly rollout. And how we kind of determine that is we're always doing surveillance, right? We're always looking at variants. We're always looking at the ability for the vaccine to still be protective against variants. So we have other mechanisms that don't include antibody testing, which I think would be really burdensome for the population. There's still potential out there, but I think it's unlikely.
All right. T. Ella says, in Michigan, manufacturing companies are in the top 5 of COVID positive exposure, yet the market hasn't been discussed as being a priority for vaccination. How has that market not been identified as a priority?
Well, I always say, if you want to know what people's priorities are, you look how they spend their money. And in COVID, you look how they spend their vaccines. So, like, I hear you, sis. And I think the problem is that there's no real sort of value for this sector of our society. If it was, they would be higher priority. Again, it's about exposure. Remember that how we prioritize people was on these basic 2 variables: risk of exposure and risk of bad outcome. So if we can't even get people to understand, if you're in a community that's high on social vulnerability, you potentially and likely have a high percentage of the population who are not able to simply shelter in place, who are not able to just take their whole, livelihood and convert it over to Zoom, like many of us with more professional type jobs were able to do. So we can't even get some of these basic priorities, and it's not being driven by data. The strategy that we've used has not been informed and driven by data. If it was, communities that had lots of these manufacturing facilities would also have higher community case rates and, greater numbers of people testing positive. I just simply, in my opinion, don't think that it's actually a big priority.
All right. So Dr. EJ, as we begin to move toward a close, if people are asking questions, they're obviously watching this rollout. They see the Johnson & Johnson information rolling out all over the news. They know about Moderna. They know about Pfizer. What would you hope they could take away from this opportunity they have with the doctor? The doctor's in. What would you hope they take away from the doctor as they try to explore Johnson & Johnson, Moderna, Pfizer, the differences? What should they take away?
I think the most important thing is get vaccinated however you can and with whichever vaccine is available to you. Once you've made that decision, I wouldn't wait. I wouldn't, try to get one or over the other and wait to get that. All of these vaccines show really great efficacy against hospitalizations or death. And that's the primary endpoint that we really, really worry about. So the biggest takeaway is get vaccinated when you can with whatever you have available to you. I think the second point is, I kind of mentioned earlier, is you may worry about the efficacy. And I think we've alluded to some of those issues and that being an important question. But the biggest thing we should be paying attention to, again, is that deaths and I just lost
hospitalizations.
Yes, deaths and hospitalizations. As many times as I said it, I lost my thought too. Thank you.
Yeah.
Those are the things you should be worried about.
All right, Dr. Deborah Verhoeven, we know that a belief in the hierarchy of human value is undergirding every system that's at play right now, including health. How does mandating equity begin to level the playing field?
The movement is about us holding the people accountable who have the power and authority to affect change, to do the right thing and affect that change. If you have power and authority and you don't use it for equity, you are now, to me, not complicit. You are an explicit part of the problem. So our job and the thing we could do, I do not like the model of us pushing for equity on our backs. I sit on the Michigan Task Force, the local Flint Task Force, and the New York City Task Force. The common denominator across all of those is you've got a whole lot of people in community working real hard to try to solve problems that really are our problems to solve, but it's our problem. But it gets taken on like it's only the community's problem. The federal government and our tax dollars paid for what's in those vials. For them to not put anything in place to ensure that these vaccines would be delivered to people and available to people fairly and equitably, to me, is criminal. It's criminal. Now, if people do the work and they look and weigh it out and say, I'm a no or a no for now, that's their right. And I'm not telling anybody to take the vaccine. I opted to take the vaccine because it made sense for me. And I'm grateful because my daughter got COVID. My daughter got COVID. And not only did I not get COVID, I didn't get sick. I had no problems. I don't regret that decision at all. But it is the most important thing that people have opportunities and fair access to everything that they need to be healthy. And this issue around COVID vaccine is just one thing, and it's an opportunity for us to really strengthen that muscle around how we need to use law, policy, and holding people to account to get that playing field leveled. If we don't, then we continue to push in the absence of pull, and that will have us continue to live sicker and die younger. And I can't stand for that. I can't stand for that.
I tell you, any day that I can close spending an hour with these two amazing docs, sharing information with our community to make sure people are informed with what they need to make the best decisions for their family, is a good day. So thank you all so much for joining us. Thank you, Dr. EJ. Thank you, Dr. Deborah Furhold, and #mandate equity. And we're out. Thank you.